All right. Welcome, everybody, to another video from Murmur MD. We've got Chris Brown, our illustrious Shockwave moderator, who also
Hey,
runs
guys.
the Complex. Hey, Chris. Who also runs the Complex PCI program at Swedish in Seattle. So, Chris, without further ado, let's see some cases and hear some cool data about the new reimbursement.
All right, let's do it. All right, so I have, let me get to the presenter mode here. Here we go. So I have a case here. This is an 80-something-year-old gentleman. Came in, has a small or a medium-sized anterior defect on a nuclear medicine scan. And I took these pictures, and I was sort of, I mean, you guys tell me what your opinion is, but I didn't think there was really anything to write home about per se. I looked at it and said, well, there might be some calcium in the proximal vessel. Maybe that sort of, in a continuous segment is causing me a problem. I'll just do physiology on it. I took some more pictures. You can kind of see there might be some sort of napkin ring piece of calcium right there. It's a little hard to appreciate though. And I think certainly this demonstrates maybe how poor angiography actually is, because I don't think that this, does a huge amount of justice. You can see there's some calcium here in this circumflex. Interestingly, the FFR of this, or the DFR, is like 96, which is very surprising to me, but I guess maybe it's because it doesn't subtend a lot of territory, but I thought that was very odd. I actually did it twice and got a new wire because I didn't believe it. Interestingly, the FFR of the LAD was actually quite bad.
Are you doing FFR, Chris, or IFR?
I'm doing IFR or DFR, and then depending on what the result is, I am giving adenosine to see if hyperemia has a significant effect on it. I will say that there are two things that I've noticed over time, and we know this is true to some degree. One is hyperemia changes even your resting indice, even though it's not supposed to. And that is what it is, and you can do what you want with that information. But the second is that, we don't always do everything the way that we're supposed to. We're supposed to give intracoronary vasodilators before we do, resting indices and things like that. I've been trying to do that or be cognizant of that for some time now. But I gave nitro multiple times here. When I did an FFR of the LAD just to be certain, because it was 88 or something by DFR, and I was like, I don't understand this exactly. This defect was much larger than that, and I turned this wire into the circumflex with the adenosine on, and it was still negative. I was very surprised by this. About everything about this circumflex surprised me. So that's sort of my two surprises. One is that circumflex, which I would argue I normally would have just said, oh, let's just treat it, but I got to the point where I'd done physiology on it because I was there, and then we're sort of, I don't want to say stuck, but I felt somewhat obligated to move forward with doing the treatment of the other vessel system. So I performed IVs here.
Are you giving IC or IV adenosine?
I'm giving IV adenosine because it takes so long for me to get the IC adenosine. I just can't do it repeatedly and fast. If I could, I would. I can get some IC drugs quickly, but not all of them. So, I IVISed here. I'm going to open the IVIS. Hopefully this doesn't freeze out everything on us.
And what value did you get?
Say again.
What value did you get on your DFR?
My DFR was 88. My FFR was like 72.
Got it.
Wow.
So.
And which IVIS is this, Chris?
I use the Boston HD IVIS.
Yeah, that's
Avigo or Azigo or something like that?
No, Avigo. So Avigo 2 or Avigo Plus is coming to the market. This is just a regular Boston HD IVIS. Avigo 2 or Avigo Plus has not been released yet, is my understanding. The original Avigo was released, but then they stopped manufacturing that to build this other catheter that I guess they're releasing. So
those are gorgeous
images. I'm just going to scroll through this. I mean, you can clearly see there's some nodular calcium. Now we're kind of getting into some more. And then there's some serious circumferential calcium with significant plaque burden. I mean, you can sort of see, you normally can't quite see the shadow with an IVIS of the media, but you can sort of appreciate that there's some positive remodeling and there's quite a bit of calcium here, more calcium than I anticipated, a little bit of eccentric calcium. And it's just me moving back and forth trying to get I'm using the sled so I can get distances. So back to my cath procedure. I'm going to go to my Shockwave pictures here.
So you use Shockwave prospectively. Had you pre-dilated or?
I pre-dilate, I guess you call it pragmatically, with a non-compliant balloon that's 1-to-1 size. I'm just trying to save this little diagonal, make sure I don't lose it. And it did not relieve at 14 atmospheres. And once I get to either 14 or 16 with a 1-to-1 NC, essentially that's when I stop. And I just move to calcium modification. And I didn't think that ring was necessarily going to relieve with an NC because the length of it's several millimeters and it's circumferential. So you can kind of predict, using the original OCT algorithms as to the MLD max as to whether you need to modify. You can see here we have a tight waist here in the Shockwave, completely gone after 10 pulses, which is sort of, where the Shockwave's bread and butter is in the circumferential calcium for sure. I mean, it modifies circumferential calcium so quickly, and it does a very good job of eccentric calcium too, but there's nothing quite like a Shockwave in circumferential calcium. So we put a stent here and just me. And then, so you can see, I mean, it's a lot bigger than I thought it was, and it has much better flow now. And you don't need to see me highlight all this stuff, but,
oh, that's gorgeous.
So interesting in the sense that the circumflex is negative. The LAD, which I wasn't particularly sold on, was quite positive and had quite a bit of calcium. And, with that lumen size too, there's very few products that I could have modified that plaque with, without having to tear up a lot of the artery, essentially spinning on high speed, with another product. I don't think a rotational device would have touched that calcium, but it was still a problem and still in my way. And so this is a nice way to sort of get through that. And this guy was a gentleman who actually presented with unstable angina maybe 4 or 5 days after his stress test. And so we actually did this as an inpatient, which sort of gets to my other thing here, which is this, which is, I think we all heard about the hospital inpatient fee schedule changes, but I don't know that we got the data, out there in a way that makes complete sense. So I'm just going to run through it really quick. I think this is less important, this slide, but the short version is that there are essentially 4 DRG pairs that are going to exist. And the question with the DRG pairs is, was a stent implanted, and then was lithotripsy used? And then those are modified by sort of other factors having to do with the patient's medical comorbidities. And so I think this slide kind of tells you what you need to know, in the sense that we mostly stick with stent because we don't spend a lot of time in the no stent realm. But, PCI with stent placement for the next year for the 2024 payment is going to be $12,767. This used to be about $13,500. So it went down a little bit. Most people don't get to this PCI with intraluminal device, 4+ arteries. They might get there with major medical comorbidities. And so that's $20,000. You can see essentially what you're getting here is about an $8,000 increase in the fee payment to the hospital for the DRG, in order to help cover the cost of the device, as well as the added time that it might take to modify calcium or to do complex calcified inpatients, end STEMIs, things like that. And I think that's a big thing for us, because if you look at the previous way that this was being done, it was a pass-through payment that was essentially just several $1,000s, about $3,500, that was just added to this or this payment. So this is a big improvement, as far as helping cover hospital costs and helping us do the best job that we can in modifying calcium and helping our patients in the best way that we know how to. And that's sort of the summary statement there. I'm going to go to one more set of slides here.
Well, that's huge, Chris. Just before you go to the next slide, so what do we do with that information? Is this just more ammunition for our administrators to justify, our existence? What do you as the guy doing 600 PCIs a year using a lot of IVL, I mean, obviously this is good for the hospitals, but what do we as the interventional cardiologists do?
I use it as the ammunition to say that, look, we have a lot of tools in our toolbox, and while they are, some of them are expensive and, not every case requires them, but that, that we have the appropriate therapies and tools to treat the patients that we see. There's, I think, nothing worse than the feeling of having somebody in front of you and not having the right things to be able to do what we need to do to fix it. And so I think that this helps, hopefully, hospitals everywhere, especially ones with non-surgical backup. We have one of those hospitals that doesn't have surgery on site that we do some procedures in here. It helps us, I think, justify some of the more advanced tools in those hospitals, because sometimes administrators don't understand or don't really know even what we're doing, in my opinion, and they don't really get that, you know, you need some of these more, you know, costly things such as atherectomy and lithotripsy and guide extensions to do certain cases. But, you know, this helps us justify those expenses in a way that perhaps we weren't able to with just that pass-through payment, which kind of sort of barely covered the balloon. I think the other important thing here is, so you can see that this was the hospital inpatient. The final ruling came in the beginning of August. It is effective October 1st. We expect that the outpatient, a similar thing will occur approximately at the beginning of November, and that will give us an effective date for the first of the year. And then the other thing is the physician fee schedule payment should come around that same timing, which is just to say that, you know, you get a small increase in RVU generation for atherectomy because it takes time, it takes a certain skill set, and you deserve something very similar or more for being able to, you know, deliver a Shockwave balloon and modify calcium safely for patients. And Shockwave has sort of really lobbied for that for the physicians. And, you know, that's I think one of the first times we've seen that in a while. So I will say that there is going to be, and we don't know exactly what's going to happen with the hospital outpatient, because the OPPS is going to close presumably before the effective date will take place. And they're also working on what they're going to do with that gap of time. But the short version is that they've done the hospital inpatient, and for your inpatients with NSTEMIs and unstable angina and such, you can now sort of, I don't want to say, you know, be relieved, but rest assured that if you need to use lithotripsy to modify your patient's calcium, that you can do that safely and without costing your hospital or without detriment to your program. And that hopefully those same changes are coming very soon to the other arenas, both outpatient as well as to physician reimbursement.
Yeah,
Well,
Chris,
awesome.
the other thing that I think about this is the, you know, getting support, having, you know, APCs for your program, right? And they end up doing, in our program, they do a lot of the coding, you know, they help with identifying the MCCs. And so I think this could really justify, you know, you're in there doing all the cases all day, having someone help with the documentation and, you know, and the orders and stuff like that to help you do, you know, you do your job. But, you know, if they're coding properly, you'll get MCCs here that'll, you know, really pay for their salaries and support the program.
Yeah.
I totally agree. And I think in addition to what Chris said about using this as leverage to get IVL if you don't have it, I think this is also leverage to get support for a CHIP program, you know, and have like a CHIP coordinator. Chris, do you have a CHIP coordinator at your center that helps schedule cases and do outreach and run the program?
Well, we have two things. I have a person who helps schedule all my cases, that's their dedicated job, and they help schedule complex things and rearrange things as needed. So I do have that support. And then the second thing is we have a sort of a program coordinator that helps run a slew of programs for us, including our STEMI program, as well as our referral program for bloodless product CABG or PCI, as well as our shock program, where we take a lot of patients in for transfer. So that person helps run all of those programs, and we're able to sort of, I guess, help service, if you will, much of Eastern Washington, as well as the Puget Sound around the Olympic National Forest and some of the other sites that maybe don't have as many resources or don't have all of the surgical backup or the tools to do some of this. And that's sort of who does that for us.
Got it. No, that's awesome. Well, this is good news. I mean, at least CMS is responding to the needs of interventionalists. They're responding to the needs of hospitals, and I think that's awesome.
I think so too.
Cool.
Well, thanks guys for having me.
Awesome. Thanks, Chris.
Sign off.
Take care.
Bye.